All right. Dr. Ruth Bristol is a pediatric neurosurgeon who made the transition to Phoenix Children's Hospital with other pediatric specialty practitioners and is proud to remain part of the Barrow Neurological Institute. She remains a member of the Barrow Children's Cleft and Craniofacial Center, which offers a team approach to children with craniosynostosis and other skull anomalies. Dr. Bristol treats all areas of pediatric neurosurgery, including brain and spine tumors, trauma, and developmental anomalies. Her research interests include brain tumors and craniosynostosis. Dr. Bristol believes that a supportive and involved family is very important for healing in children. Many children do not have the ability to understand complex medical problems, so gaining their trust and making them feel safe are essential to providing good care. Originally from New Hampshire, Dr. Bristol attended medical school at Tulane University in New Orleans. She then completed a neurological surgery residency at the Barrow Neurological Institute in Phoenix. Post-residency subspecialty training included a pediatric neurosurgery fellowship at Children's Hospital Los Angeles. Dr. Bristol practices all aspects of pediatric neurosurgery with a special interest in craniofacial disorders and hypothalamic tumors, who made the transition to Phoenix Children's Hospital with the other pediatric specialty practitioners, and is proud to remain part of the Barrow Neurological Institute. She remains a member of the Barrow Children's Cleft and Craniofacial Center, which offers a team approach to children with craniosynostosis and other skull anomalies. Thank you, Dr. Bristol. It's all yours.
Well, thank you. Let's see. All right, there we go. So for those of you in the room, sorry, the screen is in front of me. But for those of you online, good morning. It's carefully balanced. So it's a great pleasure and honor to be invited to speak today. As you'll see, I really enjoy working on craniofacial care and diagnoses, but it's always fun to be invited to explore sort of a specialty area or something a little bit new or a little bit different that I may not work on all the time. And so this was really a great little project for me to jump into. And is that better? As you'll see, we actually have a little project that we were working on with our craniosynostosis patients that kind of feeds into this, which is looking at the whole alkaline phosphatase role in bone formation. So I will say I have no disclosures. I would say maybe as a disclaimer, I think I probably have more questions than answers, at least as it relates to HPP and craniosynostosis, although for the more standard sort of neurosurgery stuff, I'm happy to answer questions about that as well. First, I'd like to acknowledge our team. So as was pointed out in my lovely introduction, I do feel that working with a team, particularly for complicated things, whether that be craniosynostosis, birth defects, HPP, I think that having a team of providers who come together really provides the best care for each individual. And so here are some of the people who've been involved most directly with the cranial part of our team. And then this is just a fun picture from the peak of COVID times when we were meeting. We meet once a month and we discuss between 4 and 6 patients at a time. And so all of these lovely people, whether they're from speech therapy or plastic surgery or psychology or genetics, they're all part of our team and we talk about each person together. So for a more general overview, I'll talk a little bit about what craniosynostosis is to start with, and then what does that have to do with our subject for today, and then are there special circumstances that need to be addressed for this HPP population. So just a background on craniosynostosis, that is what happens when one of the growth plates or the suture lines in the head closes too early. So as you all know, babies are born with growth plates or suture lines, and those have to stay open. They're there so that the human head can fit through the birth canal, and then the head can grow significantly in size in the first 2 years of life. But if any of those suture lines closes too early, whether that be prenatally or in the first year to 2 years after birth, the head can't grow in the direction it was supposed to from that suture line. And so, this is the front of a textbook titled Craniosynostosis, where this is the normal head. But then if you lose any particular suture line, you see that the head doesn't grow in the area where it was supposed to. And so here are a couple of examples of children who have like a standard craniosynostosis. So in this one, the suture line that's back behind the forehead here hasn't grown properly or has already closed. And so you see that that ends up with eye sockets that are very different sizes. The forehead is very flattened on this side and full on this side. And that has significant ramifications for all the function of those structures, right? So you can imagine the eyeball that sits in that eye socket is going to perceive the world differently than the other side. And so a lot of times babies will get a head tilt because that's what allows them to have binocular vision. And babies are very smart. Even in the first couple months of life, they figure that out. And then, as time goes on, if that affects the shape of the nose or the way the jawbone interacts with the skull, it's just sort of like a domino effect that can affect everything. And then if you look on the other side, this is a child who has sagittal synostosis. This is one of our most common ones by and large. And so that's where there's a big ridge down the middle, and that doesn't allow the head to grow from side to side. So you end up kind of with a football-shaped head. The underlying problem with any of the synostoses is, as you can imagine, if you lose a growth plate for your head may not grow enough for your brain. And one of the fundamental forces we have to deal with is that the brain is going to grow. Nothing is going to stop that. And so the brain will grow wherever it can. And so that's why you end up getting bulging in whatever area can grow and flattening where it can't. But then if you look down the road, what does this mean? Well, it means that the whole space, or what we call the intracranial volume for your brain, may not be enough. So does the brain have to do things like squeeze down the back, which is when we get a Chiari malformation? Or do you just end up getting high pressure where the brain is trying to grow out through the bone anyway? So if we look at pictures like this, here you can see where the bone has gotten thin because that brain trying to grow from side to side, but it can't. And so that over time can raise intracranial pressure. So raised intracranial pressure isn't very good for the brain. It tends to give you headaches. It can give you problems with your vision. It can give other problems with development. So it's not a one-time check kind of process. It's something we have to follow. We have to make sure over the growth and life of the patient that we get to an acceptable volume. So here's the underlying CT scan or skull picture for that patient, where you can see the vastly different shape of those eye sockets and the flattening of the forehead. And you can just sort of imagine that the brain that's behind this forehead isn't going to be very happy if it doesn't have a place to go. So when we talk about doing surgery for craniosynostosis, it's not a cosmetic thing. It's not about aesthetics, although our culture seems to be obsessed with aesthetics. It's really about restoring form and function so that the brain will be happy, the nerves, all of the neurologic structures will grow and progress as they're expected to. So I like to use patient examples, and so this is one of my patients that I've known for a great many years. I'll just very briefly recap her early history. I didn't meet her until she was several years old, but I understand that she had bowing of femurs, which was noted prenatally, and I know that that's not always a concerning finding. That can be just something that's caught, and you follow that and see where that goes. Things seemed to be appropriate at birth and delivery, but she started having spells. And you could see she had some extension of her arms and legs. There was a strange gaze and difficulty breathing. So she was brought to the hospital. I think it was a couple of times before she was finally admitted. She did require intubation. That may have been related to getting an MRI scan and not being able to be extubated. But at that time, her alkaline phosphatase was noted to be very, very low. Fortunately, she had a nice, smart, collaborating team of doctors who came together and ended up sending the appropriate labs. And so it turned out that she had pyridoxine-dependent seizures. So she was started on B6 at that time, and then eventually started on appropriate enzyme replacement therapy. So interestingly, at that time, here you can see an MRI and a CT scan that were done about the same time, very early in life. And on the MRI scan, what we're looking at is the brain itself, which looks fine, and then the fluid spaces or the ventricles here, which are nice and small, those look fine and normal. On the CAT scan, we're looking at the bone structures, and so we didn't have a 3D reconstruction, which gives you those kind of fun skeleton-looking pictures, but you can see that this growth plate and this one, they're all open at that time. So this is an infant who did not have craniosynostosis at birth. And so she, was followed by the various providers, and unfortunately, over the next few months, this is what happened. So this is hydrocephalus, and this is where the fluid spaces, if we look at what she looked like before, they were teeny tiny little normal ventricles, and unfortunately, they went on to build up lots of fluid. Hydrocephalus can be caused by a great many things. The bottom line is it's a blockage somewhere. It's the fluid not getting out to where it needs to get absorbed. And at this age, we really don't have a lot to do other than put in a shunt. And so the role of a shunt is to take that fluid from where it's being made in the head down to be absorbed in the belly. And we put a little valve in between so that fluid can't go back up. And hopefully, if it's a programmable valve, we can manage the pressure and let the head grow appropriately. So, interestingly, this is a picture of her a few years later. And you may remember from that previous slide where I was showing, actually we could just go back and look at it for fun. These are the normal suture lines. So normal suture lines should be open. They're usually kind of black and jagged, and you can just imagine those little bone spicules growing from there. But if we go forward and look at her head, you don't see any of those. And so whether this was a combination of the shunt, draining out the fluid and the pressure, or just the HPP, her sutures ended up closing. And so what ended up happening, if you look at her head growth chart, is from about age 2, which was back here, until age 6, you don't see that head growing. That was almost exactly the same measurement that she'd had 4 years earlier. And so during that time, unfortunately, she had been in and out with a lot of shunt revisions. She struggled with feeding, and unfortunately vomiting and feeding tolerance is another one of those non-specific things that can be caused by lots of different things. But when we know someone has a condition that can cause high pressure, and if they have a Chiari malformation where there's tightness on the back of the brainstem, we can't rule out those things as a source of vomiting. So we did end up doing a Chiari decompression to see if that would help. But there were still headaches after that. And so after a fair amount of discussion and looking at that head chart, we decided to make her head bigger. And so I think this is one of the more interesting developments over the last 15 or 20 years in the craniofacial world, which is the concept of distraction. And distraction is used in lots of different bones. You'll probably hear about that in other parts of the body today if you haven't already. And so the basic concept here is we go in and we make a cut around the back of the head. So it's basically like kind of cutting off the whole back of the head. And then we put these little metal distractors on. And so these are the little plates that hold them to the skull. And then these arms actually stick out through the skin. And then the family is able to turn the distractor. I think it's like a 1 turn twice a day. And that just slowly widens the bone gap so that over the course of about 3 weeks, we make the head bigger. And so this isn't something we do in newborn babies. We do this in older children where they're, well, I shouldn't say older. We do this after 6 months of age where the bone is thick enough to hold the distractors and thick enough to hold the new shape. And it's a slow enough process that my understanding is they tolerate it just fine from what the families tell us, even though it really looks pretty dramatic in the pictures. And then we let the bone sit there and we let the body grow new bone into that gap. So this is one of the interesting aspects in the HPP population where I know bone doesn't necessarily grow as expected. And so for our patient, we got out to the 3-month time frame, which is how long we usually let the gap sit there before we take off those distractors, because you don't want to take a cast off a bone before it's healed. But unfortunately, we got our CT scan and there was no bone growing there. Yeah, and she was feeling well, aside from having distractors that she didn't really want in her head anymore. And so we said, well, let's give this some more time. And we reached out to our HPP colleagues around the country and the world. And everyone said, just give it some more time and continue the enzyme therapy. And so we did. We gave it about another 3 months. And then we just had to make a leap of faith and trust some of our colleagues who had also been doing this. And we took distractors out. And she did really well. So this is about a year later where you can see that she did grow bone in between. We didn't lose the gap. And I continue to follow her for her Chiari decompression and for her shunt. And I can be a little superstitious, so I don't want to say everything's perfect, but I'll just say we had a nice annual follow-up most recently. And we'll leave it at that, and I hope that it continues that way. So this was sort of my bridging case to talk more about HPP population and craniosynostosis. In looking over the publications and the literature, it appears that the children with HPP who have craniosynostosis, some of them, so a percentage of them will present sort of like standard craniosynostosis, which is it's present at birth or we notice it in the very early years of life. And so those can really be treated sort of like any craniosynostosis patient. But there's definitely a population where it's a much slower onset, and it may not be just one suture, whereas in non-syndromic synostosis, it tends to be just one suture that's affected. HPP population, it's almost like it kind of spreads from one suture over to others. And so that, that's the difference. I think I might have some pictures here. So this is, her as an example. We don't see any suture lines on that head, whereas on a sort of quote-unquote standard case, you see, well, this first one is a single suture where just the sagittal is missing, but the other ones are open. This is a different kind of syndrome. This is Cruzon syndrome, where several sutures are affected, and you see that brain is just growing up out of any space it can. So this is a big, huge fontanelle. This is the child who doesn't have a suture line here and here, and then there are two that are sort of out of frame, but the ones on the sides are missing. But see, that's present at birth in Cruzon syndrome, whereas it's not as likely to be in HPP. So this was just sort of my background slide. I won't go through all these points for this population, but we know that if the ALPL gene is what is responsible for whether you have the alkaline phosphatase or not. We know that as presentation comes later in life, it tends to be less severe. And so in looking at some of the symptoms or things to alert providers and practitioners if this is something to be worked up, this is just a summary of symptoms and findings. And so you see that craniosynostosis and hypercalcemia with hypotonia can certainly be one of them. So I looked at literature sort of over the years. This is actually the page from that textbook I showed you the front of before with a publication from 1964 quoted. And so you can see if I blow up the line for hypophosphatasia, they only had 10 patients who were included at that time. And 3 of the patients who lived had craniosynostosis. There were also 3 infants who didn't live who had synostosis, but their overall incidence was 2/3 of their patients with hyperphosphatasia. Then this is the more recent series, obviously much larger. And again, if we look at just the craniosynostosis patients with HPP, you can see that they have a slightly different distribution. They broke it out by age of presentation. So you see the younger patients, there was more of a 3/4 percentage, whereas much less likelihood in the older presenting children. And so then this is looking at a subset of that larger group that they had published earlier where they were looking at 7 patients in particular. So you can see here the age where they presented. And as I said before, there were some that were noted quite early in life, but then there were these others who were found on a more delayed fashion. And so then they looked out at whether they had papilledema to indicate swelling behind the eyes and high pressure, and then whether they had Chiari or not. And so you can see some level of Chiari was present in the majority of them. And so that's obviously something that needs to be followed and checked into as well. So this is, as I said, we have more questions than answers really. We don't understand fully the role of TNEP in bone formation. And then I thought it was interesting to ask the question, well, has enzyme replacement therapy affected craniosynostosis incidence? And I couldn't find any evidence that it had. If we look at that early group from the 1960s, that incidence seemed to be very similar to the more recent incidents. And I thought that was interesting, especially with what I'm going to show you next, which is that in mouse and animal models, enzyme therapy can prevent synostosis. And so this is the little project we undertook. We said, well, we're doing a lot of craniosynostosis surgery. Is there anything we can learn from our patients here? And so we'll just skip down to the second to last line. Is we know that downregulation of the TNEP gene is linked to the early fusion of sutures in mouse models. And in some of those models, the enzyme replacement has been able to prevent that. So this is just a quick look at some of the science behind that. Again, this is that paper looking at the mice and taking the ALPL negative mice, and they were able to find in just a craniosynostosis model that was preventative. This is looking more specifically at cruzons, where they suggest that the TNAP deficiency may even mediate the whole FGFR, which is the gene behind cruzon synostosis. And then this is just looking more specifically at the application of the enzyme replacement therapy there that can improve that in that mouse model. So we all know it's a big leap from mice to us, but hopefully they're onto something here that can be effective someday. So just to see how this was playing out in our population, we looked at patients who underwent surgery during this 3-year period inclusive. And so we were able to collect their alkaline phosphatase levels. And so this top line, these are the youngest patients we take care of. So minimally invasive sagittals, those are usually done in the 3-month age range. You can actually see here, 3.8 was our average age range. These other children tend to undergo surgery at an older time. And then these are the syndromic patients. So we wanted to see, is the alkaline phosphatase level significantly lower in our syndromic patients? And well, maybe we're kind of hopeful here, but unfortunately we were not able to prove that. So this is just sort of the summary slide. We know that alk phos is higher in infants than it is as children get older, and so we proved that. Yay, we're keeping up with the curves. And then we did see maybe a trend that the children who had Cruzon syndrome had the lowest average level of alk phos, but they were still in the normal range. So we couldn't conclude anything from just the synostosis population. But what if we look at other children in similar ages who are coming in for other things? So we have a population, unfortunately, of trauma patients who end up getting alk phos drawn as a lab at baseline. So our next step is going to be to just compare and see, is there any measurable difference or anything that we can glean from there? So that's a little work in progress, but as I said, an interesting project to pursue. So then this is sort of my second patient I wanted to present as bridge to the next thought, who had presented with decreased feeding at 2 months of age and hypotonia. And then she was actually admitted at 4 months for a bulging fontanelle and some failure to thrive. At that time, she was found to have hypercalcemia and low alk phos, and then her gene mutation was identified. So she was initially taken care of out of state, and I have not been successful at getting the pictures, but I have the report that says no synostosis, but interestingly, the sutures appear globally widened and bones are osteopenic. So I would say that goes along with the CT scan on our first patient we looked at. That's fairly similar. They do know that there's bulging of the fontanelle, but there was no hydrocephalus at that time either. And then she actually did move to Phoenix, and so we got this scan as part of her workup here. Again, there's no hydrocephalus, but you also don't see any suture lines at this point. So this was only about 7 months later between the scan early in life, and then I think this was around a year of age. And then when we look at the 3D reconstructions, you see her sutures are now definitely not widely splayed. We don't see any coronal metopic or metopic sutures, though the sagittal and the lambdoid back there appear like they were still open. And so, she was only around a year at this point and had appeared to be growing okay. So we followed her for a little bit, but I would say she had previously been in this nice green zone here, and then over the time that we followed her here in Phoenix, she kind of dropped down a little bit. So we were starting to see a delay in head growth, and we knew that those sutures had closed, and so we had that bulging fontanelle. She was seeing ophthalmology where they did start to see some swelling behind the eyes, and so we actually had recommended a surgery for a cranial vault enlargement as well here. And then the family chose to move back to where they had been living previously. And I haven't actually had follow-up with her myself, but I do hope that our paths cross so I can learn from her and see what path she has taken. And so just in terms of some general conclusions, I think, and I don't have to tell this audience, that HPP patients definitely require a team approach, and having members of those team work together so that, if papilledema is noticed, it's not just doesn't go into a chart that nobody else ever looks at, but that it's brought together to the providers who would be able to do something about that. I do think that a baseline CT in infancy is recommended, and then careful following of head size growth so that another CT scan can be obtained if we see that head size is starting to fall off and we have any concern for suture closure. Now in this age where MRI is readily available and accessible, MRI is really the preferred way to look at the brain itself. So we've talked about Chiari malformation very briefly, but whether it's something that goes along with that patient's genetic predisposition to have a Chiari, or if it's secondary to not getting enough head growth, I don't think we have the answer to that. The incidence of Chiari in the general population is still kind of a soft number anyway, but MRI scan at some point as the child is getting older, I think is very appropriate. And then certainly by the time you get to puberty and your head is theoretically done growing, I think it would be appropriate to know where you are, where you're going to be as an adult. Do you have a Chiari? Is that something that should be kept an eye on as you get older? I think ophthalmology is incredibly useful until we have some sort of non-invasive way to measure pressure through the skull, which we don't have right now. The eye doctors have the ability to see, see into our souls through our eyes. I think that that's very useful. And then craniosynostosis surgery can be done safely. There may need to be some precautions taken for altered bone healing. We may not expect those bone gaps to fill in as they would. If you do a minimally invasive, will they need to stay in a helmet longer than someone who does not have HPP? I think as long as, again, the team is working together, those questions can all be addressed for each patient on an as needed basis. And I think that was all I had planned.